We're recording. So the illness here is can be flu. They have pneumonia. They got any upper or lower respiratory tract infections, a GI infection, any illness. So the type 1 diabetic doesn't feel well. And if they were not educated properly about sick day rules, what is your, so let's say Miss Sheila, if you were a type 1 diabetic and you were not properly educated about how your body works during periods of illness, okay, you were just told, oh, your sugar is high, you should take your insulin to keep it low. So when you get sick and cannot eat or drink properly as you would normally, would you think that your sugar will go high if you're not eating?
No, would go
No,
low.
right? A layperson would think, oh, I'm not eating. Why would my sugar go high? So why would I take my insulin? I'm sure it's low. Okay. And why would I need to check my sugar? I'm not eating. I know it's going to be low. I don't want to waste trips. Okay. So that is a common misunderstanding on the relationship between blood glucose and the readings, the levels during periods of illness. So they're not educated about how the body responds to illness. So let's review. So when you're sick, what hormones are automatically released? Doesn't have to be a physical illness. It could be stress illness, like you're constantly, busy at work, busy with school. You have exams coming up. So what happens to your hormone levels?
Increase. Your cortisol
Right,
increases.
right, very good. Cortisol is released in high amounts. And the cortisol is a glucocorticoid, so therefore it will promote the production of sugar. It will cause the breakdown of glucose from your liver, and then so on from your fat, and then um, from your muscles, okay, from protein sources. So that's the cause that led to missed doses. Other causes could be they couldn't afford the medication. They couldn't afford insulin. Let's say they during the pandemic, okay, they lost their job, can lost their insurance, can't afford insulin. Insulin's very expensive. A vial could cost you hundreds of dollars. So you probably heard of stories wherein they cross the border to Canada because they're only maybe a tenth of the price that they're sold here in the US. So Canada, because they have socialized medicine, insulin is so much cheaper over there. That could be another reason. Or they let's say the patient just couldn't manage insulin. So let's say the patient got confused or grew old, okay, had dementia, can no longer handle can't manage their insulin anymore. Or this is the example we give in case the patient got sick or got exposed to really high stress levels. And then the patient was just diagnosed with type 1 diabetes. They had no idea they were diabetic. Frequently, type 1 diabetes is diagnosed when they're already in DKA, meaning for a long time they had no idea they had type 1 diabetes. And then the first time they're diagnosed is when they're admitted for DKA already. So that's the common scenario for type 1 diabetics. So this is a hyperglycemic complication, unlike hypoglycemia. So you have severe hyperglycemia causes the appearance of the three P's because now you have increased osmotic pressure. As the blood sugar rises in the blood sugar levels rises in your bloodstream, it will cause via osmosis, the water will be absorbed from your cells, right? So the cells become dehydrated, and then that will increase blood volume. Therefore, increased blood volume results to, you know this story, right? Or do you want me to explain this? The three P's. Because you've had diabetes already last semester.
Yeah, but just I guess refresh it. I don't know. I don't know.
Okay, fine. Okay, see the whiteboard?
No, not yet.
See the whiteboard?
Yeah.
Yeah.
Yeah. So these are your cells, and this is a capillary, let's say. This is a vessel. So now you have increased blood sugar here for the causes we just mentioned. So the patient missed their insulin either because they didn't know they were diabetic, or they were diabetic and didn't know how to manage illness, diabetes during periods of illness, not knowing that not eating actually doesn't cause hypoglycemia, but instead because you're under stress, your sugar is actually increasing because of cortisol. So this is now the scenario. So these molecules here represent glucose molecules. So it thickens the blood, correct? Because now your blood has the same consistency as Slurpee. So in order to balance the two compartments, so this is vascular, so this is extracellular, this is the ECF, this is the ICF, intracellular, extracellular. So to balance it, since glucose cannot enter the cell without insulin, the only thing that can move is water. So water via osmosis moves, and we talked about this 2 weeks ago, that osmosis is movement of water from an area of lesser concentration to an area of greater concentration. So this movement of water dehydrates the cells because now they lose water, and so blood volume increases. When they reach the kidneys, in the kidneys, they sense the increased blood volume here, so therefore the kidneys will make more urine because that is their job, to regulate fluid and electrolytes. So they sense the increased blood volume, they will make more urine, resulting in polyuria. The patient, meanwhile, the cells are continuously dehydrated because the cycle of um, counter-regulatory mechanisms of producing more sugar is already on. So the patient here is, we have hyperglycemia, and there is no insulin. So here they're stuck in this cycle right here. No insulin leads to hyperglycemia, then hyperglycemia causes this, and therefore no insulin will cause further hyperglycemia, because in between here, because there is no insulin, you have your counter-regulatory mechanisms. Counter-regulatory are your glycogenesis, uh, glyco, yeah, glycogenolysis, which is turning glycogen to glucose. Then you have your ketogenesis and gluconeogenesis, right? So these three processes here occur in between. So no insulin, meaning the patient can't get to the sugar, so the cells here are hungry, leading to your second P, which is now polyphagia. So the hunger here results from the lack of insulin, but really the problem here is that not a lack of sugar, but then the lack of insulin causes the vicious cycle of counter-regulatory mechanisms being stimulated. These will all contribute to further hyperglycemia, and then the more hyperglycemic the patient becomes, the hungrier the cells become. This will go on, and this dehydration will also continue, causing your third P, the polydipsia. And here we are, we're caught in this cycle where we cannot get out of. So your patient's stuck in this situation until they either die from dehydration or die from the ketosis that results from the fat breakdown. So we are now having the 3Ps, and then the only thing that can stop this is the insulin, which the patient doesn't have for the reasons already stated. So without treatment, patient eventually becomes hypotensive, could go into shock. So we call this hypovolemic shock. To compensate, the patient will attempt to neutralize the acidity caused by the ketone bodies by increasing respirations. Doing so loses CO2 because CO2 is carbonic acid. So if you lose it, then your body becomes more alkalinic. So again, this is a compensatory mechanism at an attempt to neutralize the acidity of the plasma of the blood. And this is another symptom. So the presence of acetone at high levels in the blood resulting from the ketone bodies results in a fruity aroma. Over time, the dehydration will lead to severe acidosis, leads to nausea, vomiting, and then the more acidic you become, then you go lethargic, coma, and die. How do we make a diagnosis of DKA? These are your manifestations. So you draw blood. The sugar here starts at greater than 250. Don't interpret this as DKA will have only a blood sugar of about 251. No, this only means that the DKA, this condition here we're talking about, starts early at 251. Some books say 300, doesn't make that big of a deal. Meaning, the moment the patient hits 251, then these things now appear. All those things we talked about in the whiteboard, the explanation begins at 251. So does it take a long time before a patient develops DKA, or does it develop quick? How long does it take for your sugar to reach 250? Does it take several days or a few hours?
Few
A
hours.
few hours.
Only a few hours. So therefore, DKA can occur. Let's say you're fine now. You could be in DKA this afternoon, right after lunch. Okay, it develops that fast. Because there is absolutely no insulin, so that's why there is ketosis resulting from fat breakdown. Doesn't happen in HHS, right? Because in HHS, the type 2 diabetic still has some insulin, although not enough, but they won't develop ketosis in HHS because they still have some insulin preventing, or if any fat breakdown occurs, it's very little. Because of the presence of ketones in the blood, the pH will of course turn acidic. So the ABG will show a pH of less than 7.3. That's already moderate acidosis. Bicarbonate, of course, is also going to be acidic. Um, this one is already less than 18, and normal level is 22 to 26, correct? Never mind the positive anion gap. This is for the physician. Our concerns are these. Okay, so how do we treat a patient in DKA? You saw the pathophysiology. The patient is very dehydrated because of the osmotic diuresis resulting from uncontrolled hyperglycemia. So they will receive a lot of fluids. Okay, so they will be given at least 1 liter of normal saline during the first hour, and then during the same first hour after you hang the fluids, because fluids are first because it's ABC. So airway, breathing, circulation first before you go to insulin. So as soon as you finish hanging the NS, now you give insulin. The insulin here will be um, two doses. The first dose is bolus. Let me see if we have the dose here. No. Okay, so the dose is 0.1 units per kilogram. That's the bolus. So we give it IV. What's the only insulin given IV?
Regular.
Okay, so you draw up regular insulin into and then push it IV. So that means you'll have to transfer it to a lower lock syringe. So here is your um, vial. You can see the whiteboard, right?
Yeah.
Okay, and this is your insulin syringe. So you draw up, let's say I'm 60 kilograms times 0.1 units per kilogram. So how many units will I receive for the bolus dose? Hello?
6.
Okay, so I get 6 units. Okay, so you'll have a math question on this for exam 1. So I draw up 6 units. So let's say this is 6 units right here. How do I give this IV? Since this needle cannot be removed from the insulin syringe, it's attached, so it's impossible to give this IV. All our IV access are needleless, so you'll have to transfer this into a lower lock syringe. So this is now a 10 ml saline flush. So this is filled with saline, so just push back on the pull back on the plunger, make space, put this in here because this is sterile, put your insulin in there, so now you have your insulin here. Since this is lower lock, you can now screw this into your patient's IV site, the port, and then you push the insulin. So this is your bolus. Now you have to give insulin infusion. The insulin infusion comes in a 250 ml bag. So the label is insulin 250 units in 250 ml of, let's say, NS. Okay, this is a bag. So 0.1 units per kilogram per hour. How many mLs per hour will you infuse the continuous insulin infusion? I weigh 60 kilograms. This is the other math question on exam 1.
Okay. Hello?
Yeah, go ahead. How many mLs per hour?
Mm,
Israel, are you calculating, sir? You've been awfully quiet today.
Oh yeah, yeah. I'm calculating. I just been soaking it all in.
Oh, well, don't soak too much. Come on, people. So 60 times 0.1 equals 6 divided by 250 times 250 equals
6.
6 mLs per hour. So now we've given the bolus, we gave the patient bolus, we gave the patient a continuous infusion. Any questions so far? So the whole time the patient is receiving the NS, so this is running over an hour. At the same time, after you hang this, now you give your patient the insulin bolus, you give them a continuous insulin infusion. The whole time you have to correct the electrolyte imbalances. Now, what electrolyte imbalance is this? Going back to fluid and electrolytes, we said under potassium imbalances because we looked at the management of hyperkalemia. What was the fastest way we lower potassium level? Miss Corbin?
To give
No, K-Xylate, remember, don't choose
Oh
that.
no, you give.
That
Is
takes
is it to give
You
insulin?
can give insulin with
with
glucose or something.
with insulin with dextrose, right?
Yeah.
So what's the difference between that and this one? This is also given insulin, right?
Yeah.
So we're giving
But we're giving the other one. We're giving insulin to lower the potassium because when it like goes hand in hand. Like the more insulin, the more like when you give the insulin, it would lower the potassium, but it will also lower the glucose level. But that's why we would give the glucose with it.
Okay, very good. So in the case of DKA and HHS, we're giving IV insulin for what purpose? To lower what?
Lower the glucose.
Oh, glucose level.
Okay, very good. However, are you saying this type of insulin is racist? It will only lower glucose and not lower potassium?
No, it's not racist.
It's not?
No,
It's racist?
no, it's not racist.
So the insulin we gave in the electrolyte chapter under hyperkalemia is not racist, and this one, the insulin you give here, is racist because it will only lower glucose and not lower potassium.
You do the same thing.
It will also lower potassium. You saw that in hyperkalemia, correct? So if you give IV insulin, what will happen to this patient's potassium level?
Hypokalemia.
It would
It would go
decrease.
down.
It will drop. So is your statement going to be if the potassium drops or when the potassium drops?
No, when it drops.
Okay, it will drop because you're giving continuous IV insulin infusion. So do we wait until it drops and then correct it?
No.
No. We
Take
should.
preventative measures.
Okay. So would it help if we add potassium to the IV bag while the insulin is running?
Yes.
Yeah.
Yes. Okay. So after the first hour here, so you're giving saline, right? And the whole time you also give one insulin bolus and then a continuous IV infusion. So you have two bags here hanging. One is running saline, one is running insulin. So 1 hour later, the saline bag is now empty. It's finished. So now you're gonna have to replace that. Remember what the cell's conditions were. Were the cells dehydrated?
Yeah.
Very dehydrated, right? Because the blood was pulling all that water. That's why the patient had polyuria. Because remember, this patient had dehydration from osmotic diuresis. So this diuresis is caused by the increased osmolarity of the blood because there was so high sugar there. So now you'll have to fix the cells. So after the bag of normal saline, 1 liter, the blood pressure is fine. So we're done with the ABC. So the circulation is fixed. Blood pressure is back to normal. Now we have to go fix the cells. So do we stay with isotonic fluid here?
No, you had
Okay,
hypotonic.
so what type of fluid will be hung next to fix the
Hypotonic.
hypo what?
Tonic.
Hypo or hyper?
Hyper.
Hypotonic.
Hypo. Would it be
Okay.
hypo
Are you
because
asking me or are you telling me?
No, I remember
I'm
she said it's hypo.
I'm kind of telling but asking at the same
How-
time. I was thinking hypo because
Gonna
if
pull the potassium from this. I think it's
No, it
hyper.
has nothing to do with potassium. We're
I
It's
concerned about
hypo.
I
cells.
think
Cells are
I
Oh,
think
okay.
it's
Okay.
dehydrated.
hy-
So
fluid to go
if
into the cell, so it's hypo.
I think
okay,
it's
so
hypo because
all
the
right.
cells are dehydrated, so it wouldn't need any more nutrients. It would just need like the water, well, to get
Okay.
hydrated.
Okay. So we now switch our IV to a hypotonic solution. Give me an example of a hypotonic IV solution. So on the exam, it won't say hypotonic fluids. It will actually say an
Half
IV.
normal saline.
Very good. So we have
0.9.
half normal saline, 0.45%
Oh.
NS. So we're going to add potassium into that bag. So we have floor stocks. When I say floor stocks, these are standard bags that have potassium. So you'll grab a bag 0.45% with 10 or 20 milliequivalents of potassium in it. So of course the doctor will give you that order. So he'll change it after the NS is done. He'll give you another bag. Okay, this time give half normal saline with 10 or sometimes 20 milliequivalents of potassium per liter in anticipation of the potassium drop. Hypokalemia will occur because you're giving insulin IV. So to prevent that, we do it ahead. So here it is. The explanation for the hypokalemia. Okay, it's you're also losing some potassium during the polyuria, but because of insulin administration now, this will also cause more hypokalemia. Throughout the procedure, the treatment, we could go into hypoglycemia, but this section here is talking about the
Professor,
three
I
acute
can't see your screen.
oh, sorry. Okay, I was reading this one, the safety alert. So here, just read this on your own. Hypokalemia results from the polyuria, plus you also have hypokalemia resulting from the insulin administration. Okay, this section here is not a continuation of DKA. Okay, DKA stops here in this chapter. It stops right here. This one is a separate topic talking about hypoglycemia. Now, however, we do have hypoglycemia occurring here, right? We could potentially do that because of the IV insulin administration. DKA is considered resolved if our blood glucose is now below 200. If we hit below 200, the patient is no longer in DKA, meaning once we hit below 200, is the vicious cycle still going? The where we looked at lack of insulin causes hyperglycemia, and then hyperglycemia causes more breakdown of sugar, and then still no insulin. Remember that part? That vicious cycle is now stopped because now you have insulin. So therefore, will the body still continue to break down glycogen?
No.
Will the body still continue to break down fat?
No.
Will it
No.
continue to break down protein?
Yeah.
No.
All
Oh.
those stop because
Yeah.
now you have insulin on board. So therefore, is the patient still in DKA?
No.
No.
More. Okay, so that's your cue. So once it's fixed, then the acute episode is finished. We just continue to replace the fluids. Okay, so once we hit 200, we stop the insulin infusion. Doctor will say, okay, discontinue that, and then we just continue with the fluid replacement. Okay, because it will take time, because that was a lot of fluid that the patient lost, and we can't just dump it one time. So it has to be the fluid deficit there has to be corrected more slowly now over several hours. Any question on DKA?
No.
All right, so the next one for HHS is going to go faster because the management is really the same. It will only be slightly different. Where is, because this is type 1. Okay. Forgot this book. Put it separately under type 2. Okay, so here type 2 diabetes, we have HHS as a complication down here. Okay, so here is complications. So we said patient with type 2 can have DKA or HHS, right? This time, let's just discuss HHS and compare it with DKA.
Wait.
So, yeah,
Sorry. So HHS is a complication of DKA.
no,
Okay.
type 2 diabetics.
Okay, type 2. Okay, sorry.
But the only difference here is in DKA, what's their insulin?
It's above 250.
No. It's their insulin in DKA.
Their
600.
insulin.
Because remember who gets DKA?
Mhm.
Type 1.
Type 1.
Type 1
And
diabetes.
occasionally type 2, right? If the type 2 patient experiences severe stress. Okay.
Yes.
So remember that DKA developed because there was absolutely zero insulin. HHS develops because there is not enough insulin.
Insulin. Yeah.
Okay. So in DKA, when did it start? What was the blood sugar level? Where in
It's gonna be
DKA?
very
Yeah.
high. It's gonna be
What was
about
the exact number?
600.
No. DKA.
No, 251.
250. Okay,
251.
above 250.
The kid.
So it's developed over a few hours. Here in HHS, does it take a long time or a short time to reach above 600? And remember, the condition here in type 2, they have not enough insulin. So does your blood glucose go from 0 to 600 in a matter of hours or in a matter of days?
Hours. I would say hours.
Yeah.
Takes time.
Days.
This will be several days because
Oh.
remember, the patient still has insulin, although the insulin is not enough though. So in order to reach 600, this is several days in the making. Okay, so this is not an acute, I mean, this is an acute complication, but we're talking about several days here. So will the patient notice the signs over several days, or will they learn to disregard it because, oh, I've been diabetic, I've just not been
Yeah,
taking
they
care.
might ignore it.
Right, because plus there is no ketosis here. There is no Kussmaul's respiration. Look at the patient's only symptoms. The patient only has, let's see, where did they put the signs and symptoms? Here. So all patient feels is dehydration. And when you're dehydrated, is there confusion?
Yes.
Yeah.
Yes.
Yeah.
Mm-hmm.
You get confused. Are you aware when you're confused? Are you aware? If somebody's confused, are they aware that they're confused? Because it's not the same as what you guys say on the exam. When you say, oh, I was confused on the exam, you're not really confused. Because true confusion means I mean, you're not aware that you're confused, right? The fact that you're aware that you're confused during the test means you're not really confused. Does that make sense?
Right. It's kind of like a crazy. It's kind of like a crazy person saying they're crazy. They're not really crazy.
Yeah, yeah. Anyway, forget that. Okay, so in HHS, the problem here is there is not enough insulin. Unlike DKA, wherein there is absolutely no insulin. So remember the drawing we did earlier, same exact problem. However, because there is no absolute absence of insulin, there's only insufficient insulin, there will be no ketosis. That's the only thing different in HHS. That's why the sugar reaches higher, meaning the HHS condition doesn't begin until it reaches 600. Okay, unlike DKA, wherein the condition starts earlier at over 250. This one really doesn't start until it's above 600. Because of this pathophysiology, who is more dehydrated, the DKA patient or the HHS patient?
HHS.
The HHS patient is more dehydrated because how long did they sustain the dehydration? Over several days. Remember that the patient in DKA developed it over several hours. So the dehydration that they were exposed to was only for a few hours. Unlike here, an HHS patient, their sugar remained high, constantly rising over several days until they hit above 600. So all the while, before they got to 600, did they have osmotic diuresis the whole time?
Yes.
Yes, so the whole time they were having polyuria, polydipsia, polyphagia. The whole time, those several days until they hit 600. All right. Now, don't take it literally. In DKA, I know we said that the condition starts above 250. The patient in DKA, if they don't receive insulin, they can also reach 600. They can reach 800. They can reach 1,000 milligrams per deciliter of sugar. All right. All the chapter was saying in DKA was the condition starts above 250. It didn't mean that they will never go higher than 250. Of course, they'll go as high as they can. It really depends on how soon did they go to the hospital. All right, that you reach them sooner, then the better outcome. In HHS though, because of the subtle changes over time, and again, the condition develops slowly. So until they reach 600 though, there was several damage already done to the patient's body. So the whole time they were in severe dehydration. So therefore the dehydration here is more profound and the patient has more severe electrolyte imbalances compared to a DKA patient. Okay. You can skip this part here because we already know that type 2 diabetics can develop DKA. And we already discussed DKA. So if the type 2 diabetic develops DKA, we already looked at the management. So we're over that. Let's look at the diagnosis and management of HHS now. And here's another proof. Okay, HHS has a higher mortality than DKA because again the damage here occurred longer, unlike DKA wherein it was over a few hours, okay, several hours. This one is days in the making. So the damage here is longer and is more therefore more profound. The patient's more dehydrated and more dehydrated for a longer period of time. So these patients may, by the time they come in, they're already in AKI. They're already, or probably they'll lose their kidneys by the time they're admitted because the whole time the kidneys were suffering AKI. And at that point, maybe the kidneys will simply go oliguric already. Okay, you may not see the polyuria anymore because the patient already went into AKI. So diagnosis-wise, this is what we see. So the sugars are way higher compared to DKA, shown by the really high osmolarity. Look at that, 320. Normal is around in the hundreds. There's profound dehydration. This time the pH, because there's no acidosis, there's no fat breakdown, it is either normal or alkaline. So it's either 7.31, which is only slightly acidic, because there is a possibility that there will be some ketone formation, but not that serious in order to cause severe acidosis. And here, the opposite. In DKA, we had a bicarbonate less than 18. This one is greater than 18. Small, if any, ketone bodies. Okay, so either small or none ketone levels in the urine. And like I said, because of the severe dehydration, patients confused at this point. The management is exactly the same as in DKA, only the fluids are at higher levels, meaning since they're more dehydrated, so therefore will they receive less or more IV fluids compared to DKA? Hello?
More because they're dehydrated?
Very good. Will they receive less or more insulin compared to DKA?
Less because the sugar is really high. So
No, they'll
So,
get more insulin.
They get
all
more
right.
correctly.
Okay, so of course they'll get more insulin because the sugar is higher.
yeah.
Right? That's the only difference. And one thing we forgot to mention in DKA is because we forgot about the acidosis. So we fixed the dehydration, we fixed the blood sugar. We didn't do anything about the acidosis. So for acidosis, the patient will be given bicarbonate. However, they don't throw bicarbonate around because really what's causing the acidosis in DKA? What led to it?
The acidosis.
Yeah, in
Too
DKA.
many ketones.
Yeah, why was there so many ketones? What caused the whole thing? Why did the body, the type 1 diabetic's body, break down fat?
It's because the patient was starving. I don't know. I wasn't getting enough sugar. No. Or insulin.
Okay, very good.
Yeah.
So there was no insulin. So really, if you fix the cause, which was lack of insulin, we gave insulin. Do we really need to necessarily fix the acidosis?
No, because that would
Or will
regulate
it fix
its
itself?
own. It
Right.
would
So it
fix
will
itself.
fix itself, right? However, if the patient has really severe acidosis, we can't wait for the body to fix it. We have to give bicarbonate. So only if the pH is now less than 7, which is severe, then the patient receives bicarbonate. Because otherwise you'll have severe brain damage already. Okay, so if the acidosis is severe, meaning the pH is now less than 7, patient has to receive bicarbonate because you can't risk encephalopathy, okay, from the severe acidosis. So here in HHS, do they need bicarbonate? Is there acidosis?
Is there acidosis?
No. No.
Very little. Okay, it's only 7.3. It's definitely greater than 7.3, so this is at least 7.31. So yes, but will they ever reach severe acidosis? No, because there is no fat breakdown in HHS, or very little. See here, small or even absent ketones. Any question on HHS and DKA? All right, let's take a break.
Okay, thank you.
Come back at 10:50. 10:55. Okay, 10:55.